doing what is the scope and how can you treat your patients. While, yeah, the second speaker, Prof, came from London. She's my colleague, but he took radiology in Liverpool. He also kindly joined this webinar. And Dr. Kunte, this webinar run monthly. This is the 8th webinar since the pandemic, so we try to still run our academic performance, even though it's limited. Let's see if...
Dr. Kunte, how the pandemic situation in your country nowadays? I hope everything it's okay. Sorry, you're okay.
Yeah, now I well, it's yesterday we crossed around 2.34 lakh cases per day. So
wow.
The situation is really worrisome.
Wow.
The hospital beds and remdesivir, and there's a shortage. The government is working hard to get things back in order, but the sheer volume of patients that we are experiencing per day, it's quite threatening, in fact. So I hope that this second wave passes very soon, and we resume our routine as soon as possible.
Yes, yes. We hope to. We hope so.
We have here with us our Dean. Assalamualaikum. Good afternoon, Dr. Ruslin.
Assalamualaikum. Good afternoon, everybody. Good afternoon, my Vice Rector, Professor Sumbangan Baja, and also with the distinguished speaker, Dr. Farun Kunte. Nice to meet you.
Okay, ladies and gentlemen, Prof and Doc, thank you for being here with us. And I think we all here now, Dr. Kunte here, our Vice Rector, Professor Sumbangan Baja, and here our Dean, Dr. Muhammad Ruslin, and Dr. Ruslin, Prof. Sumbangan Baja, here our first speaker, Dr. Farun Kunte. Our MC today is Dr. Denis Setiawati, Master in Public Health, PhD. She will help us guide this event. I leave it to you, Dr. Denis. Dr. Denis, let me see. I couldn't hear you. Let me see.
Dr. Denis have not unmute your audio.
You haven't unmute, Dr. Denis. Let me try to help you.
Okay.
Okay.
Yeah, the host still not allowed me to unmute myself.
I'm sorry, Dr. Denis.
That's okay.
It's me.
Can we start now? Okay. Good afternoon, everyone. Welcome and thank you for joining in the 8th Virtual International Symposium series held by Faculty of Dentistry, Hasanuddin University Makassar in collaboration with Faculty of Dental Medicine, Universitas Airlangga, Surabaya. My name is Dini and I will be the Master of Ceremony for today's symposium. Today we have two remarkable speakers, Dr. Farun R. Kunte, PDS MDS, and also Dr. Priyanka Shakavalkar, PDS MDS MSc. Our symposium will be started with the opening speech from Vice Rector of Universitas Hasanuddin Makassar, Professor Dr. Insinyur Sumbangan Baja, MPhil. Then in the next 40 minutes, we will have lecture about biometrics in temporomandibular disorder and discussion time reduction delivered by Dr. Farun R. Kunte, PDS MDS, followed by 20 minutes discussion and certificate of appreciation virtual delivery to the speaker. After that, in the subsequent 30 minutes, we will have the second lecture about CBCT application in dentistry delivered by Dr. Priyanka Shakavalkar, BDS MDS MSc, followed by 10 minutes discussion and certificate of appreciation virtual delivery to the speaker. At the end of the symposium today, the Dean of Faculty of Dentistry Hasanuddin University Makassar, Dr. Giki Muhammad Ruslin, MKes PhD, SPBM Consultant, will give closing speech. Okay, to begin our symposium today, I would like to invite Vice Rector of Hasanuddin University Makassar, Professor Dr. Insinyur Sumbangan Baja MPhil, to give an opening speech.
Okay, thank you. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon. I think in UK is in the morning. Good morning. The Dean of Faculty of Dentistry, Hasanuddin University, and I think all of his vice dean, the Honorable Chairman of Senate, Faculty of Dentistry, Hasanuddin University, our distinguished speakers, Dr. Farun R. Kunte, the founder of and CEO, Arthrose Craniofacial Pain and Tmg Center in India. And the second speaker, I think, Dr. Priyanka Sakafalkar, University of Liverpool in UK. Distinguished guests, colleagues, ladies and gentlemen. First of all, I'd like to welcome you, to you all, to the virtual international symposium. I think this is the 8th series of the program of the Faculty of Dentistry, University of Hasanuddin. A glance through the schedule of this symposium, I think it is very interesting. It reveals the amazing topic will be given by the two speakers. Dr. Farun will present a very interesting topic about biometrics, I think, in TMD. And also our second speaker will give a discussion about application, CBCT application in dentistry. I think this is a very interesting topic for the Faculty of Dentistry, especially for the researcher and also for our students now in the faculty. Ladies and gentlemen, as we all know that Faculty of Dentistry is one of 16 faculty in Hasanuddin University. And this faculty has shown itself a very fast growth in terms of a number of students and also a number of international events like this. And also, I think a number of output of research that already been done by the lecturer and also student in the Faculty of Dentistry, Hasanuddin University. We are very happy with the achievement of this faculty, actually, of course, and in terms of fulfilling our 3 missions of higher education institution: education, research, and also community service. To support the academic activities in this faculty, we have also a dental hospital. So Dr. Kunte, in university, we have also a dental hospital that provides services to students for academic activity and also provide service to community in this region. And the present of this dental hospital is give very much contribution to the university and also to the people or community around this region. And to in promoting research activity, this actually become the focus of our university program recently. We encourage the faculty to do a lot of research and also to present the result of research in the international event like this. And I think the discussion today will give a very big contribution to our research in terms of enhancing their topic of research, especially in the topic of CBCT application in dentistry, and also discussion about biometrics and Tmg, I think. In this university also, because of that, a lot of activity done for international event, we have allocate quite some amount of budget to provide international activities like this, and also to run inbound and outbound program for lecture. Maybe someday, if Dr. Kunte, if you have a time, I think after this pandemic, you can become our inbound lecturer, I think, in this university. And also Dr. Priyanka, I think the Dean will talk with you about it. Ladies and gentlemen, of course, the symposium or conference such as this provide a valuable opportunity for research and scientists, and also in industry specialists, and also decision makers to share experience. I'm very grateful to the many lecturers who have attended and joined this discussion to discuss and share knowledge and experience to this symposium. I also welcome the representative of government, if there are any, industry association, and also postgraduate students, and our, I think, undergraduate students that, who have joined this symposium. I'm sure you will have fruitful and rewarding exchange during this symposium. I wish you every success with this important symposium, and we look forward to learning about the outcome of this conference. Once again, I would like to thank the Dean, and especially the organizing committee of this symposium, and also two of our prominent speakers today, and all participants. Enjoy your symposium and enjoy your discussion. And in the name of Allah, I declare that virtual International Symposium Series number 8, organized by the Faculty of Dentistry, Hasanuddin University, is officially open. Thank you very much. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Okay, now I would like to introduce the moderator for the first and the second lecture today, Dr. Gigi Fadil Ulum AR, Specialist Dental Radiology. Before I hand over to the moderator, let me briefly read his curriculum vitae. Dr. Gigi Fadil Ulum AR, specialist in dental radiology, was born in Makassar on 13th of December 1987. He earned his DDS degree from Faculty of Dental Medicine, Hasanuddin University, Makassar in 2012. Then he graduated from Dental Maxillofacial Radiology Specialist Program in Faculty of Dental Medicine, Pajajaran University Bandung in 2020. He's currently a lecturer in Dental Maxillofacial Radiology Department of Faculty of Dentistry, Hasanuddin University Makassar. He's also a member of Indonesian Association of Dental Maxillofacial Radiology. He has a number of research projects and publications in dental maxillofacial radiology topics. Well, now I will hand over to Dr. Gigi Fadil, and he will lead the lecture agenda from both speakers today. Dr. Gigi Fadil, I hand over to you. Thank you.
Thank you very much, the Master of the Ceremony, Dr. Denis Setiawati, for your introduction. The Honorable, the speakers of this session, Dr. Farun Kunte, BDS, DDS, and Dr. Priyanka Sakavalkar, BDS, MDS, MSc. The Honorable, the Vice Rector of Hasanuddin University, Makassar, Indonesia, Professor Dr. Insinyur Sumbangan Baja, Master of Philosophy. The Honorable, the Dean of Faculty of Dentistry of Hasanuddin University, Dr. Gigi M. Ruslin, MKes, SPBM, Consultant PhD, and the Dean of the Faculty of Dental Medicine, Universitas Airlangga, Dr. Gigi Agung Sosiawan, MH, MHKes, the Honorable, all of the Professor and Doctor, and all of the participants. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Thankful for God's presence. Alhamdulillah. Salawat to the great Prophet of Muhammad SAW for the Muslims. And I would like to say happy fasting for all the Muslim participants in here. And hopefully it doesn't affect our enthusiasm to take a part in this webinar. Before we continue our webinar, maybe I invite the Dean of the Faculty of Dentistry of Hasanuddin University. Oh, sorry, the Dean in the closing speech. So, hello everyone, and symposium in session 8. Thank you for you all of you, for spending time and joining with us for today's webinar. My name is Fadlul Abdul Rahman. I will be responsible for hosting this session, and I'm glad to welcome both of our outstanding speakers today, whom I believe shall enrich our knowledge, our insights regarding advanced imaging in dentistry, imaging modalities, and their use in dentistry to diagnosis and treatment plans nowadays. Next, technically, our two presenters will deliver their presentation sequentially, starting with Dr. Kunte as the first presenter and Dr. Priyanka as the second presenter. And the question and answer session will place at the end of each session. Okay, before the presentation begin, allow me to provide you the curriculum vitae of the first presenter. I'm sorry, I didn't prepare the PowerPoint for your curriculum vitae, Dr. Kunte. I just read your curriculum vitae. Our first speaker is Dr. Farun R. Kunte. He was born on September 6, 1988. He has hobbies in traveling, reading, and music, and he has specialty in orofacial pain and Tmg, trained by Dr. Ben Shatter in Dtr therapy, trained in neuromuscular dentistry in ICCMO, expert in dental sleep medicine, expert in dentomaxillofacial radiology, especially in cone beam computed tomography or CBCT, and orofacial diagnostic and therapeutics. And he had graduation from Maharashtra University of Health Science for for his BDS or Bachelor of Dental Surgery and MDS in Oral Medicine and Radiology. And he is the second person in India to get certified in this disclosion time reduction therapy in TMG. It's a very outstanding, Dr. Kunte. There are so many projects, there are so many research publication, and the latest is in 2017, Conservative and Orthodontic Management of Maxillary Midline Diastema, published in International Journal of Current Research in July 2017. Okay. Hello, Dr. Kunte. Are you there?
Yes, hello.
Okay. Yeah, in this session, Dr. Kunte will deliver a presentation entitled Biometrics in TMD and Disclosion Time Reduction. But before you start your presentation, could I ask you a question?
Yeah, sure. Please go on.
Okay, I'm interested in part of your CV as a founder of TMG Center in Mumbai, India, and you are the second person in India who gets certified in DTR. Maybe you can please tell us a brief description about it, maybe about your background or your activity in your TMG center, or how do you use the radiographic or imaging modalities to support your job in there? Because in my opinion, understanding of TMG, TMD, and how we use the imaging for make a definitive diagnosis for temporomandibular joint disorder is one of the most difficult things in our field in dentomaxillofacial radiology. Maybe you can take a little share for us.
Well, yes, indeed. A lot of things about TMJ disorders is not known. But to start with an analysis of temporomandibular joint disorder, one would typically require two things. One is the structural analysis and the second is the functional analysis. So number one, the structural analysis is where the cone beam CT and MRIs and radiographs come into the picture, where we analyze damage to the bony component or damage to the disc or soft tissue component, bone marrow edemas. And when we talk about second part, that is functional analysis, that is where the most of the world is lacking, because the equipment which are used for analyzing this functional component are there's not much awareness about them. So these equipment are called as biometric equipment. And so today I'm going to talk to you briefly about these biometric equipment and how they can be game changers. So it's not just the equipment that we have, but what do you do with these equipment? So a small illustration is something called as DTR, Disclosion Time Reduction. I'll be talking about it in the lecture. So when we talk about TMJ imaging, what is lacking so far is the biometric aspect. So hence I chose the topic about biometric and DTR today. So I hope you'll find it interesting. And I wish that more and more people from all around the globe take up this science, and together we help develop new protocols of the 21st century.
Okay, thank you very much, Dr. Kunte. That sounds interesting, I think. Well, Dr. Kunte, you will have 40 minutes for presenting your presentation, and approximately 15 until 20 minutes. After that would be the Q&A for your session. For all of the audience, you can write down your question and your name in the chat box on the Zoom platform during the presentation, and I will read your question in the Q&A session. Ladies and gentlemen, please welcome Dr. Farun Arkunte. Dr. Farun Arkunte, the time is yours.
Well, thank you. I'm going to share my screen with you all. So very good afternoon, one and all. Namaste from India. The very meaning of Namaste is that I bow down to the greatness, or I bow down to the divine in you. So Assalamu alaikum, everyone. I am delighted to speak to you all this August afternoon, especially to people from Indonesia. I was fascinated to learn that Indonesia happens to be the largest island country in the world.
Yes.
And it's so close from India, and I was not aware of that. And a mystic beauty of Indonesia has always been told to us. We have seen pictures of Indonesia, but I never had opportunity to visit. But now, post-pandemic, I hope that I'll definitely visit the country. I
Hopefully.
also hear that Indonesia is a land of Komodo dragons and Sumatran tigers. So there's something we share in common. We have a lot of them here in India. And I invite you all to visit my beautiful country. I also know that Indonesia is fastly becoming one of the most developed nations in the world. It is a booming economy, and I hope in coming years, Indonesia, along with India, we become world superpowers. So I speak to you from land of color, culture, and courage. I speak to you from India, a land of philosophers, thinkers, and warriors. So before we go on to our presentation, I'm going to start. This presentation, in fact, is a story. I'm going to narrate this story, and this story is about a young guy called as Dr. Robert Kirstein. You can see his picture. Dr. Robert in United States was starting out as a prosthodontic postgraduate resident, and he stumbled across something called as T-scan. A T-scan was an equipment which was there in his department. He had no clue what this equipment was, and he was trying to find what this equipment is and whether he can use it for his dissertation. In the process, Dr. Robert studied T-scan. In the T-scan, there's something called as handle, and there's something called as sensor. So this sensor, on these sensors, the patients were asked to bite, okay? And it digitally read the forces on top of all the teeth. So essentially, what we do with articulating papers, the same thing was done digitally and far more superiorly. So this story is about Dr. Robert Kirstein. I had a distinct opportunity to learn from the master himself a couple of years back, and he's a phenomenal individual. He came up with something called as disclusion time reduction, and we'll be, of course, discussing this. But in order to do so, he developed biometric equipment. Now, biometric equipment are essentially 4 equipment. So I'm going to tell you each equipment one by one. There are a few others also who helped him in this journey. And essentially, these companies are Myotronics and Bioresearch, who are mainly involved with measurement of bite forces, measurement of muscle activity, measurement of TM joint vibrations, or the computerized tracking of the mandibular movements, that is jaw tracking. So Robert put forth a theory that we all know, and that theory is canine guidance. So let me tell you what canine guidance is. So when you are chewing your food and going in an excursion, right lateral or left lateral, what happens is that in the canine guidance, all the posterior teeth disclude. And this disclusion of posterior teeth has to happen in a particular amount of time. Robert, along with his mentors, did a lot of research and found that this disclusion time, the amount of time you require to achieve canine guidance and separate the posterior teeth, is around 0.41 seconds. So it has to be less than 0.41 seconds. Now it's very interesting to know why it is 0.41 seconds. Okay, as you all know that our posterior teeth control the muscle activity of the temporalis, masseter, and all other muscles. Even now, why don't we do an exercise? All of you, please put your fingers on the temporalis muscle and try biting hard on your back teeth. you can feel the muscle if you bite hard, or put it on the masseter and try biting hard on your teeth. You can actually feel your masseter moving. So these are your teeth that are controlling the muscle activity. And who controls teeth? We dentists. So in turn, we have the power to control the muscle activity, right? So Robert came to know that there are some special sensors in this posterior teeth. He called them mechanoceptors. They're in the PDL. So when you bite hard, these mechanoceptors get activated, and they synapse directly in the CNS, and then it causes muscle activity. So the more, the number of sensors engaged, if the posterior friction is more, the muscle activity would be more, right? So if in the chewing, if your back teeth are not getting separated, and if you have group function, okay, where all the back teeth are touching, and if that back teeth are touching and if they are causing muscle activity, then there is a chance that your muscles will work for more time and they will rest for less time. So let me give you an example. We all are here. We all are working by the day because we take a good night's sleep in the night. Now consider a scenario where you haven't slept for 3 days. Will you be able to work on the 4th day? Absolutely not. You'll be very tired. Same way, if your muscles are working for more time and they are resting for less time, eventually the muscle fatigue builds in. And then these muscles start aching. All right. And this is what we call as myofascial pain. Right? So what governs the myofascial pain is muscle hyperactivity. What is caused by muscle hyperactivity is basically the friction in the teeth. So lack of canine guidance and posterior friction caused all this. In the sense, if the posterior teeth discluded quite early on, the friction would be less, muscles will be more efficient, muscle activity would be less, and the patient will not suffer from myofascial pain. That is what he realized. And then he proposed something called as disclosion time reduction. Now in disclosion time reduction, what he did is he tried to shorten this disclosion time by building a canine guidance and swift disclosion of the posteriors. So what Robert ensured is that when you're biting or when your teeth are in occlusion, they are giving you good muscle activity. The muscles are getting recruited very well. However, when you're chewing and when you are grinding the food, all the muscles are simultaneously relaxed. That is what he ensured by giving them canine guidance and reducing the friction from the posterior teeth, right? In doing so, he required the help of some equipment. And we are going to see this equipment because it is relevant to our today's topic, advanced imaging, right? So this is nothing but an imaging, but a different kind of one where you don't have CT scans, MRIs, or X-rays, but where you have some latest biometric equipment, which shell out some important data. So a very important, and the most important rather, is something called as T-scan. So this is the T-scan Novus, the latest one. Now, as you can see, this is the handle of the T-scan, which you hold in your hand. And this particular portion, the green thing, is the sensor. And this goes in patient's mouth, right? And you ask patient to perform the chewing movements. Now, what are these chewing movements? You ask them to bite hard, okay? The second would be to bite hard and, slide right. So right lateral excursion, like this. The third would be to do the same thing, but on the left side, which is left lateral excursion. And the fourth thing is the protrusion. So in each movement, you try and find where are the high forces, okay? Where are the occlusal interferences? Where are occlusal prematurities? And the beauty is that the second machine is Emg Electromyography. What it does is it measures the muscle activity of masseter, temporalis, and some other surface muscles. So both these run in same timeline. So for an example, if you have a premature contact on 3/6, you can actually come to know whether that premature contact is causing certain amount of muscle activity or hyperactivity or not. So you are able to image these muscles in real time when they are put to the function, right? God has designed our chewing pattern to be circular or elliptical, right? We don't chew like, if we chew like this, we'll get tired in no time. If we recruit that much muscle activity, we'll be tired, and that is why we chew. So in the chewing process, simultaneous rest is to be provided. But in most of the temporomandibular joint disorders cases, this chewing mechanism has taken a hit due to XYZ reasons. And when this chewing mechanism takes a hit, there is certain amount of occlusal imbalance, there's certain amount of muscular imbalance, and then that causes muscle hyperactivity and eventually pain. So by this equipment, T-scan, we measure the bite forces. With EMG, we measure the muscle activity, right? So let me give you an example. On the right-hand side of the screen, what you can see here, where my cursor is, it is T-scan, right? Now, let us not get into the technicalities because it's beyond the scope of this presentation today. However, let me give you a short explanation about this. If you can see a highlighted circle here, it says 2.15 seconds. Now, I told you that the disclusion time, okay, has to be less than 0.4 seconds. Am I right? So here it is saying 2.15 seconds. That means this patient, whenever she is chewing, 5 times more load is there on her muscles, 5 times. All right. So if you see this, this is the EMG reading. In the center here, we expect good and uniform amount of muscle activity. But in the periphery here, we expect very minimal muscle activity. But if you can see, her muscles are active for a long time. So these red ones are temporalis and the green ones are masseters. So both the temporalis and the masseters are active for a long time. We expect muscle activity like this. In the periphery, we'll expect like this or this, but not like this or not like this. All right. So what we did is we did the DTR for her. So in the DTR, we tried to shorten this disclusion time. We took out interferences from the posterior teeth by our micromotor and by the aeroter. I'll tell you where we adjusted. We tried to build the canine guidance here, tried to enforce the good canine guidance here. And after the DTR was done, now if you notice, the disclusion time is just 0.23, which is less than 0.4, so which is normal. Earlier it was 2.15, 10 times more. So now there is a 10 times reduction in the disclusion time. And you see this, there's a significant amount of reduction in the muscle activity. So now muscles are able to perform the same function with reduced muscle activity, right? And all this is imaged in real time. Nothing is arbitrary. Nothing, the articulating papers which we use, their accuracy for force reproduction is very less. It ranges from 13% to 38%. So the modality of the 80% of time, it does not tell you where are high forces. Very, very critical. But we all are using it for our work daily, right? And you know what is our accuracy as dentists to determine, you know, where is the high force and where is not, using articulating paper. Ben and Robert, Dr. Ben Sutter, my mentor, and Dr. Robert Kirstein did a study back in 2017 where they found out that our accuracy is just 13%, 13, only 13% accuracy. So T-scan is about 95% accurate. In the force reproduction, you see commonly normal readings on T-scan for 95% of the time, which are accurate. So T-scan is really the way to go. EMG is, of course, important to study the muscle activity. Now, we come to the third modality. That is called as JVA. The name is Joint Vibration Analysis. All right. So if you can see here, this is one of my patients. So this is the joint vibration analysis. So there are two sensors here, which are there on top of the TMJ. And we ask patient to open, close, open, close. All right. So if there is any clicking sound, the vibrations which are generated by this clicking sound are studied by the JVA. For an example, this is the JVA scan of the same patient that we saw. Now, if you see the readings here, there are 80 and 36. Now the normal readings are less than 20, 20. All right. So this is 4 times more than normal, and this is 2 times more than normal. And if you see the waveform here, okay, so what is normal is something like this, a straight line, all right, or this. But this particular thing is a very loud click. It's a clicking sound. So that's causing an active damage to the TMJ, all right. Now we have treated the same person with disclusion time reduction therapy. And after disclusion time reduction, see it's written first sitting of DTR. In just first sitting, the value now is back to normal. It's less than 20 here, less than 20 here. And look at the waveform. Pretty much normal, right? Quite normal. You remember the old one? It was like an ECG reading, quite high. Now it's almost linear. So there's a definitive improvement. So by doing this, by doing DTR, before and after, we always measure with our biometric equipments to make sure that whatever treatment that we have done, it is beneficial to the patient. Patient's subjective and objective signs are matching with what we have done. So it is not based on what patient says or what doctor thinks. It's actually as simple as looking at in a computer screen and performing your treatment and making sure that you've done it right. If you have not done it right, you can do it again. Simple, right? You do this day in and day out. In fact, DTR requires a very small calibration in the teeth. Most of us are used to cutting down teeth for crown preparation. So I think this is extremely easy for a dentist. Any and everybody can learn this. This is absolutely not rocket science. And I would be more than willing to teach you all. It's only beneficial that through you, we will be able to reach more and more patients. And we'll be able to expand the boundaries of biometric world today, right? The fourth and the final biometric equipment is essentially the jaw tracker. So what it does is that it, in a computerized manner, it tracks the movement of the mandible, okay, and it gives us certain graphs. It also has the ability to talk to EMG, to talk to JVA. So what happens is that suppose if you are having clicking TMJ on the left side, okay, and if your jaw is deviating to avoid that clicking, you will come to know that on the jaw tracker that your mandible is moving in an arc to prevent the disc from slipping. Also, the jaw tracker talks to the EMG. So for an example, if you have a clicking sound and the jaw tracker shows that your mandible is moving to avoid the displacing of the disc, then the EMG readings will also show what kind of an additional strain is being put on the muscles to compensate for this movement. So really what it does is it opens your eyes to an unseen world. Why temporomandibular joint disorders are so enigmatic, that's why they are so elusive, because we were not able to study the bite forces. We were not able to see the muscle activity. We were only seeing the pain, myofascial pain. We were only seeing the clicks or reduced mouth opening. We were not able to see whether those clicks are causing enough damage or whether body is accommodating those clicks, whether there's not significant damage. So not every TMJ click has to be treated. But to know which ones are to be treated, you need to evaluate using these equipment, and they will only help you in your treatment plan. Now, this is the jaw tracker. So just to give you an example, this is normal. So this is the way patient opens the mouth, and this is the way patient closes the mouth. All is in one smooth arc, right? But if you see here, patient tries to open, but then it goes inside, then it comes out, then it's all wavy. So that was abnormal, right? So you expect a smooth mandibular movement. So all these are the biometric equipment with which we analyze the functional, digital, and dynamic data of the entire craniofacial region, right? And what do you do with this data? So there are a number of techniques, so there are a number of treatments that we can do with this. But today I'm going to talk about one of them, which is quite simple and which all of us can do. And it is called as DTR, right? So we are going to talk to, we're going to discuss the DTR in three parts. Number one, how it is done, okay? Number two, when to do the DTR. And number three, which is I think more important, as it when not to do DTR. Okay, the DTR is not a magic bullet where you can use it for every TM joint disorder case. No, it's not that. It's quite selective in terms of which patient you can do. So case selection is very important, right? So let us talk about the first part, that is how to perform disclusion time reduction. The answer to this is ICAGD, immediate, complete, anterior guidance development. Immediate, complete, anterior guidance development. So what you do is that what is the cause of a muscle hyperactivity? The cause of a muscle hyperactivity mostly is a function occlusion, a lot of posterior friction that causes the muscle activity. So you rule out the posterior friction. How do you rule out the posterior friction? Simple. You build the canines. The canines, if they are worn out, you build them. You create a contact between upper and lower canine, as in what you expect in a class 1 canine relationship. And then whatever additional friction you have in the posterior teeth, you calibrate. Calibrate as in you do very fine reduction. Not all cases have to be, in occlusion doesn't have to be touched in all cases. Very selected cases you need to do. Also, mind you, it is not in millimeters. The correction is in microns. There is no grinding. There's no reduction in cusp height. We are not flattening teeth at all. It is very, 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 very precise. And that is why a very precise science has to be used, like T-scan and EMG and JVAs and JTs. Why do we invest so much in the equipment? Because we don't want to be harming the patient in the process of treating them with irreversible treatment modalities. So you need to be very sure before you even take down microns of enamel, because it's not going to grow back. And what if somebody does this to your teeth? You won't forgive him, right? So we have to be very, very gentle with what we do. The essential goals are, number one, is to maintain uniform force distribution, right? That's what all we want. We want good forces on the front and back teeth, right and left, upper and lower, uniform force distribution. All teeth coming simultaneously or together in contact. That's what we want. We don't want any premature occlusal contact. So what T-scan does is, it maps the bite forces, but wait, with respect to time. It will give you the timing of the force as well. So where you can actually come to know which tooth came in contact first, which came in later, which is premature, which is not. So it really opens up the world of digital occlusion to you, and treating patients or calibrating them for implants, calibrating them for full mouth rehabs, or even occlusal equilibrium becomes very, very, very simple. Everybody can do it. Even our graduate students can do it. Really, right? The third objective is that we take out all the occlusal interferences. Now, what do you mean by occlusal interference? It's a very unique term, and there's a lot of classifications and there are a lot of things about occlusal interferences. The answer is very simple. I told you that all teeth should come in contact almost immediately. That timing is called as occlusion time, the time it takes to get all teeth together. This time is around 0.2 seconds. So whatever stays beyond 0.2 seconds to get all teeth in contact, good occlusion, that is an occlusal premature, right? That is an interference, okay? And what typically we call interference is that, suppose if we are asking patients to go for right lateral excursion or left lateral excursion, in the process when patient starts moving to the right side or left side, beyond 0.4 seconds, whatever teeth remain in contact or whatever part of the tooth remains in contact, that is an occlusal interference. Because when you are moving teeth to the sideways, naturally you're going to have some contact. Naturally, you're going to have some skid marks, right? But then how do we determine which is an interference and which is a normal skid mark or which is a normal contact? The contact on T-scan which stays beyond 0.4 seconds. And one more thing, if it causes more muscle activity, only then that is an interference. Why do I say that? Most of us, we are about 120 or 130 people here. And most of us will have group function because we have evolved that way with tiny jaws now. Now, most of us will have group function. Does that mean all of us should have canine guidance and swift disclusion times and we should start cutting down your enamel? Absolutely no. Absolutely no. So if your group function is causing or is resulting into an excessive muscle hyperactivity, only then you need to get it treated. Otherwise, you don't touch the teeth at all. Let it be. I mean, even if there's group function, fine. If you measure and if you find muscle activity, please treat it. So the occlusal interference is when you take your jaw to the right or left side and that part which stays in contact beyond the disclusion time, beyond 0.4 seconds, and which causes muscle activity is an occlusal interference, right? So the fourth goal is to shorten the disclusion time and eliminate posterior friction. As the lesser the friction, lesser would be the muscles secreted, easier would be the jaw movements, right? So it looks something like this. So this is before treatment. If you see, there are a lot of markings here and there. So what we do is we essentially keep the contact on the working cusps, okay? And we take out the contact from the non-working cusps. So here, what we do is we adjust on the cuspal inclines. We usually don't touch the cuspal height. If you touch the cuspal heights, then patient may have cheek bite, or if you reduce here, then he may have tongue bite, right? So what we do is we mainly manage the cuspal inclines, and we keep the point occlusion as prescribed by Robert Custine or as prescribed by Dawson, right? So we keep the point occlusion. So something like this. So there's a very nice point here, right? Here. But if you see everywhere else, now it is the friction is reduced. And we make sure that by reducing this, the muscle activity in the center when you're clenching is uniform. But when you're going to the side, the muscle activity is taken off. So your muscles perform well and they are able to breathe more oxygen, perform more activity with less number of muscle fibers, right? So something like this. Now, this particular part stays in contact beyond 0.4 seconds. So this is at 0.4 second. At 0.4 second, this stays in contact. There's not good canine guidance here. There's no good canine guidance. So this is an occlusal interference. This is an occlusal interference. And there is lack of canine guidance. So what do? Do we take out from this? Do we adjust teeth here? So, no, absolutely not. We have to build the canine guidance here. You may not have to touch the posterior teeth at all. So what we did for this patient is she had disclusion time around 0.63. She had facial pain. She had headache. She has TMJ clicking. And you know what? She has tinnitus, constant ringing sensation in the ear. And what was causing it? This additional muscle activity. We wanted muscle activity like this, but this additional extra muscle activity was causing the tinnitus for her. Right? The exact mechanism is not known, but what happened is after we treated her for DTR, the disclusion time is 0.26. There is good canine guidance now. There is no posterior friction. And look in the center. Wow, what a good muscle activity she has now. And in the periphery, very, very minimal muscle activity. And she had no pain after treatment. She had 70% reduction in tinnitus. She was told that there's no hope. There's no hope for tinnitus. We can't get you better. We have tried everything that we can, but no hope. And a simple therapy called as DTR helped her with her tinnitus, facial pain, headache. You have a power to do something which most neurosurgeons, which most ENTs, which most MD medicines and surgeons will not be able to do. But a simple visit to a dentist can get you better. Unbelievable, right? But we've been doing this day and night here in India. I would be happy to share all of that with you, right? When next patient you see the disclusion time is 2.43 seconds. So everything that stays in contact beyond 0.4 seconds here is an interference. So you have interference with 2.6, 2.7, 2.4, 2.5, right? So what we did is we took care of these interferences. Now the disclosion time is 0.17 and the muscle activity is much better. She's a singer, she's a Bollywood singer, this lady, and she was not able to, sing high notes because whenever she used to open her jaw, she used to get a lot of pain in the masseters and temporalis. So after doing this, she's able to sing well. She's able to make the jaw movements very easily, and there's no pain. So simple DTR helped her. A few sessions, 3 to 4 sessions of DTR helped her to get better, right? Now, when to do DTR? That's also a very valid question. So there's a very detailed protocol, and there's some symptom checklists that we analyze. There detailed history, there is postural evaluation, there is radiological evaluation, namely CBCT and MRI. So if there is, let us say, very high osteoarthritic changes, then DTR cannot be done because the joint may not respond to any change that we throw at it, right? A very severe case of osteoarthritic TMJ may not respond well to DTR because a lot of damage is already done. And the source of pain a lot of times is arthrogenic. It is coming from the TMJ itself. So by treating the occlusion and muscles, we may not get there, right? So it's not done in every case. So we have to make sure that the osteoarthritic changes are minimal. Why MRI? Because if the disc is displaced and it's torn, no matter what you do, you're not going to get a stable activity because by doing the chewing movements, you're actually loading the TMJs. And if your TMJ is not in a stable condition, then it may not accept the load and it will in fact cause more pain. So DTR is not done for every TMJ case. It is done for very selective cases. And the number one criteria is that you have minimal osteoarthritic changes and the disc displacement is fine, but disc displacement without reduction, where the mouth opening is reduced and disc is locked, that is usually not allowed, right? You should have at least a certain pole, lateral pole of the disc or a medial pole of the disc on top of the condyle for doing DTR, right? We also need to know that whether patient is a mouth breather or not, or whether he has sleep apnea or not. So we need to treat this patient for sleep apnea. There are other things as well. I mean, if there are dento-maxillofacial abnormalities like narrow palate, class 2, typical, we're going to see a video. So DTR may not help in these cases, right? So there we need to adopt a more comprehensive solutions like neuromuscular dentistry, like number of other things, right? Along with that, it is coupled with an intraoral exam to see whether there is any canine coupling or not, whether there is any arch size or shape discrepancy where you have high arch palate, narrow maxilla, any nasal deviations, all these things if you have. Apart from that, there's also a psychiatric assessment because a lot of TMD patients do suffer from pain and that pain do affects their mental stability. And after all this is done, then we jump to the T-scan, EMG, JVA, and jaw tracker. It's not loosely, done. It is done after a very careful evaluation. Only then all this thing is done. Once the data is compiled, a treatment plan is made, and whichever treatment is planned, that is rendered. So DTR is essentially there for myogenous part of TMJ disorders. So TMJ essentially is not just temporomandibular joint. It is teeth, muscles, and joint, right? The TMJ stands for teeth, muscles, and joint. And DTR is going to take care of the first two components. We are going to directly influence teeth and muscles, but joints we cannot influence directly. We can only influence them indirectly. So DTR is mainly for myogenous temporomandibular joint disorder, myofascial pain, right? Provided you have a stable TMJ, provided you don't have a very significant class 2, or you don't have an anterior open bite, all these things, if you don't have, then yes, then you can do a DTR. So TMJ disorders are quite complex, and why they are complex? Because essentially the world is confused because there are a lot of concepts and a lot of theories like centric relation, neuromuscular, stomatognathic, so many things, biopsychosocial, so many theories, so many concepts, but you're not willing to, image and screen with our own eyes. So it's like 6 blind men in the room, and there's a big elephant in the room. So this particular guy is touching the elephant's ear and he thinks it's a carpet, right? So it's an ENT. It's an ENT surgeon. This guy is probably also an ENT, which is touching the nose or the trunk of the elephant, and he thinks it's a snake, it's a python. This guy is a dentist, is touching the tooth, the tusk of the elephant, and it thinks that it's a spear. This guy is touching the elephant's body and thinks it's a tree. This guy is touching the tail and he's thinking it's a rope. So basically, we are all 6 blind men finding in the dark what is happening with TMJ disorders. What is actually required is to take off those sunglasses and see the elephant from all angles, not just dentist angles, not just TMJ doctors angles, but ENT, neuro, psychiatrist, everybody's angle. And it requires a multidisciplinary management. Only then we will be able to treat TMJ disorders quite comprehensively. And also we need to understand that one treatment is not a solution for TMJ disorder, right? So only one treatment is not a solution. We need to have a comprehensive treatment plan for TMJ disorders.
Sorry, Dr. Kunte, you have 15 minutes left.
Sure.
Thank you.
So we were talking about something called as physiologic tolerance. Now, all of us have different physiologic tolerance, right? This here is an Arnold Schwarzenegger, the Terminator guy, right? Now, his muscles are really well built. So his muscles can take up a lot more muscle activity than this particular skinny guy, right? So somebody with a very poor physiologic tolerance or very poor muscle strength can still have symptoms in spite of treating them with DTR or in spite of treating them for TMJ disorders. So what is very essential is that you ask your patients to have good nutrition and build good muscle strength, because essentially in chewing or in any activity like swallowing, you're going to engage the muscles. And even that amount of engagement causes your muscles to be sore, then you need to increase your muscle strength as well. So a lot of times my patients ask me the question that, doctor, my jaws have been like this for past 20 years, but why do I have pain just now? If the problem was with my jaws, I would have had pain 20 years back. The answer to this is there is something called as physiologic tolerance, and then there is something called as disease level. So it takes a certain amount of time for the disease level to surpass the physiologic tolerance. And when it does so, you get symptoms. Now, typically, if you are going through a stressful period, your physiologic tolerance is down. So you will feel the disease more. Hence, there is an increased amount of research which says that TMJ is stress related. It's not entirely stress related. Stress is one of the causative factors. Whenever you're going through a stressful period, you will have more amount of symptoms because your body cannot tackle it. That is why. So typically for women who are, let us say, having hormonal imbalance, so that causes less physiologic tolerance. The physiologic tolerance goes down, and when it goes down, you can experience more symptoms, right? So it takes a certain amount of time for disease to evolve, and only after it has evolved a particular stage where your body cannot tackle it anymore, only then you will have all the problems. So hence the symptoms are subjective. Somebody may say that I'm absolutely fine, but may still exhibit muscle hyperactivity, and later on he or she may develop symptoms. So what you should actually look for are signs of wear down, signs of teeth breakdown, signs of muscle soreness. And what helps you in doing so is biometric equipments like T-scan, EMG, JVA, and jaw tracker. So it analyzes the data objectively without any subjective bias. So we all are here as doctors, and we may have different opinions, and we are entitled to our opinions. But when we analyze something objectively, it rules out the confusion, right? So as an opinion, it can be right or wrong, but when you see it on a computer screen, it's usually right? It's not subjective, it's quite objective science. The same way our imaging is, that the CBCT and MRI or radiographs is quite objective, right? So TMJ is quite more complex, and what we are going to see now is the illustration that why TMJs are complex and why you have all the pains and in TMJ disorders.
Airway and Tmj. The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt. The result is a deformation of the lower arch known as the bicuspid drop-off. The result of this deformation of the upper and lower arches is the presence of premature contacts upon closing, which shift the lower jaw distally off of the physiologic trajectory. The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward. Upon opening, the disc can shift onto the condyle to restore the TMJ's correct position, reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headaches. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backwards. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
All these symptoms are seen in TMJ disorders, and that video shows exactly how the symptoms develop. So if patient has all these things, then we need to treat them more comprehensively, considering all the factors like that. And we are not just tooth doctors. And why I tell you, because even a small filling that you do has a great impact on the posture. So there was this study that was done, a famous rat study. So what they did is, they added a 0.5 millimeter filling on the right first molar of the rat. And after 1 month, see how the spine changed. Great, right? They added one more 0.5 millimeter filling on the left first molar of the rat, and see the spine came back in center after a month. So it's really what we do as dentists, full mouth rehabs, implants, all that has implications of neck, back, everywhere, right? So if you do it right, you could be solving a lot of these problems as well. So as dentists, we have a power beyond our imagination. And it is just for us to recognize this and start the treatment, right? So the last part is where I discuss that when not to do the DTR. Very simple, that if you have an anterior open bite, if you don't have canine coupling, you cannot do the DTR, right? You need to build an anterior guidance. If there are severe degenerative changes in the condyle, you cannot do that. If the group function is there, but it's not causing any muscle hyperactivity, then you shouldn't touch the occlusion at all. Dentoskeletal deformities and arthrogenous TMJ disorders, where the displacement of the disc has caused the more problem, not just the occlusion. So first we need to get the disc back in place, stabilize the TMJ, and then go ahead with techniques such as DTR. So it's not a magic bullet. It reduces the intensity, frequency, and duration of the symptoms. It is done in about 3 to 5 sittings. And it's very essential to correct all other factors and then do the DTR. So don't say that, I'll do the DTR and everything will magically fall back in place. It doesn't work like that. It only treats the myofascial pain, right? For all other TMJ disorders, a more comprehensive solution is a neuromuscular dentistry, which is of course beyond the scope of this discussion. So we will discuss that hopefully in future. So here's one of my patients treated with the principles of DTR, Niyati.
So Niyati, when we first saw you, you were suffering from severe headaches, severe facial pain, a lot of sensitivity in your teeth, and the pain was in fact radiating to neck and shoulders.
Yes.
Am I right?
Yes.
And you also complained that the left side of the entire body was also aching.
Yes.
So we digitally checked you with T-scan, which evaluates your jaw function. We also hooked you up with EMGs, which checks your muscle function. We had joint vibration analysis for your status of TMJ. And after analyzing thoroughly, we came to a point where we suggested you disclosion time reduction therapy, DTR, which essentially balances the forces on your jaw and thereby balancing the forces on your muscles.
Yes.
Right? So after the few rounds of DTR session was done, how do you feel? I mean, initially, how bad was your pain and what is the present status now?
I would like to say that the major change in my lifestyle is that now I'm able to chew from both sides of my jaw. Earlier, I was suffering from so much pain that I just avoided eating from my left side of mouth. So now there is no imbalance in chewing and there is no pain as such. I do not suffer from headache as well. And about sensitivity, yes, there is sensitivity here and there, but that is mainly because of the food that I eat. But I'm sure in next few sittings the sensitivity also be gone. I was suffering from sensitivity for last, I guess, 20 years. So since my childhood I was avoiding having ice cream and all that stuff which has sourness to it. So but from last 2 months I think I am able to eat all the fruits. I'm able to eat all the types of food which people try to avoid because of sensitivity.
That's really nice to hear. So a huge impact.
Yes.
With a simple procedure.
Yes.
I mean, it was completely painless.
It was completely
right?
painless. It was not at all time consuming, and there was no daily sit-ups or daily follow-ups.
So we didn't poke you with any injections, right?
No injections.
Completely pain-free.
Completely pain-free. Yes.
That's great. That's great. So on a scale of 0 to 10,
yes.
How bad was your headache?
The headache was 8.
Headache was 8, and today, as we are speaking, how bad is it?
It's 0.
0. That's amazing. And say sensitivity was 10, if
yes,
I remember.
Yes.
So how bad is it now?
It is not bad, I would say. It is just comes and goes. Whenever it comes, it's 3 to 4. So I won't say it bad.
That's manageable?
That's manageable.
Okay, that's great. And how about facial pain? How bad was it?
Facial pain was 9. I would say 9 or 9.5. And now it is 2.
That's perfect. That's really reassuring.
Yes.
So you're glad that you visited Arthros and got yourself treated with DTR?
Yes, I'm sure. I'm very glad that Dr. Amruta suggested me to visit you. I did not waste any time identifying my issues anywhere else. I was directed and I was suggested the right treatment for my pain, and I think the solution which you provided was the best, and I think this is a lifetime solution and not a temporary treatment. So once you are treated with your jaw issue, I think throughout my life, at least for next few years, I won't be suffering from any such issues.
That's good. The awareness about these things are pretty low, and that is the reason why we are doing this. So that more and more doctors and more and more patients can know about such treatments and can be helped with simple solutions such as DTR.
Yes.
So that was our patient Niyati, and she was suffering from a lot of craniofacial pain, headaches, migraines, and sensitivity. And now with DTR, it's quite manageable. It's almost all gone. It's been around couple of years to her treatment now, and she's quite stable yet. This is my picture when I had an opportunity to meet the man himself, Dr. Robert Kirstein, and I got trained under him for a few days, and it was a life-changing experience. So in conclusion, I would like to say that there are biometrics in TMD. Biometrics is the way of analyzing the bite forces, muscle activity, jaw movements, and the joint clicking sound or vibrations. DTR, neuromuscular dentistry are an efficient treatment modalities. We have seen a very brief overview about DTR. And remember, we are not just tooth doctors. We have a power to do much more. We have a power to treat migraines, headaches, craniofacial pain. We have power to influence the posture. And most of our medical colleagues may not be able to do that, but then a simple dental procedure can help you in doing so. So oral physicians are the perfect fit for treating TMJ disorders. And I believe that more and more people can imbibe this science of biometrics, and together on a global scale, we can achieve much more. So thank you so much for listening to me so patiently for all this while. Anybody who wants to reach me, this is our website. This is my contact number and email ID. Please feel free to share any cases that you have, and I'll be glad to help you out to the best of my abilities. And together we can learn more. Thank you. Thank you so much.
Thank you very much, Dr. Kunte, for an awesome presentation. And now we move to question and answer session. But before it, could I ask you again? Yeah, in your presentation, you write down that radiological approach is one of the protocol in DTR, and you mentioned the CBCT and MRI. The question is, how if there is no CBCT or MRI? So we just use conventional radiography or 2D radiography, whether the DTR can be implemented or no, Dr. Kunte? Thank you.
I think that's a clinical decision that we have to make. But when designing a protocol, and as it is mandated by the mentors, it is mandatory to have a CBCT as per the protocol. But if the patient is not, let us say on an OPG or a TMJ view, you don't see any signs of osteoarthritis and patient is not having any clicking sound whatsoever, I think it's fair to say that you can skip it. But for the one that I have realized that we do the TMJ, CBCT and everything, and we do it we analyze it in quite extensive manner. There are a lot of, I would be happy to share some articles with you. And we do that for each and every patient. So I am more comfortable knowing all the parameters and then treating the patient. But yes, it can be done. It's a clinical situation, right?
Okay, thank you very much. And your presentation open our eyes that the temporomandibular joint disorder is need multidisciplinary approach to treat, because it's just not about the teeth, it just not just about the muscle, but it's the complexity in there. Okay, there is a question in the chat box from Dr. Tenri Biba. She is a specialist in prosthodontics. She asked, was there an association between frequent loose anterior fillings and wrong canine guidance? Thank you.
Could you repeat the question, please?
Okay. Dr. Tenri Biba asked you, was there an association between frequent loose anterior fillings and wrong canine guidance?
Okay, you're asking about the worn out anteriors and canine guidance. Is that what you're asking?
Pardon me?
Is it about the worn out anterior teeth and the wrong canine guidance, or?
Yes, about the if anterior fillings is loose or from
So essentially, see, the TMJ is a very dynamic joint and it responds to the forces, and these forces are essentially transmitted to the TMJ with a stable occlusion, and then the muscle. So there's a occlusion here, there are muscles here, and then there's a TMJ. So anything, suppose if you build a canine guidance which is very shallow, or if your anterior restorations become loose, if they're not providing enough guidance. So this additional muscle activity that is there, no, it's putting more force on the TMJ. So there is more chance of the damage to the TMJ, more wear and tear, more chances of disc being slipped. Also, body will try to protect the TMJ. So in the process of doing that, it will try to compensate this problem by either wearing out of the dentition, or slipping the disc. Something will happen. There are those patients who may have very nice dentition, but then a displaced disc, right? Or there are those patients who have no clicking sound, but they have quite the severe attrition, quite the severe occlusal wear, right? So it is a compensatory response of the craniofacial region to protect the structure that it deems more vital. So if it decides to protect the teeth, then the joint will take the hit. If it decides to protect the joint, then the occlusion will take the hit. So when we are restoring in anterior region, we need to make sure that there is good contact on the anterior teeth. It is giving good protrusive guidance. It is giving good lateral excursive guidance. That is what essentially what we are doing. So we are following all the principles of occlusion. Whichever philosophy you may follow, may follow centric occlusions, MIP, centric relation, neuromuscular, whichever. Essentially, there are some common rules in between all the philosophies, and we are trying to follow the same rules.
Okay, thank you, Dr. Kunte. So the key is how we protect the TMG with controlling the force in the TMG area, in the tooth, and the complexity in there. Okay, Dr. Ernie, you can unmute your audio and ask directly to Dr. Kunte.
Thank you, Dr. Fadil, to allow me to ask. What a brilliant presentation, Dr. Kunte. Thank you so much. And it's quite tempting that you offer us to teach us to train us how to do this DTR. And I hopefully we can invite you again someday. Maybe not next month, but next other month, about the next step or other associated treatment for the pain, myofascial pain. What I would like to know, Doc, from your experience, have you ever combined a medicine with the DTR for managing the pain? And
yes. Yes, we have. But in cases, initially when we do the first session of DTR, when I say that the muscles are paining or muscles are aching, essentially there's a lactic acid buildup in the muscles. The muscles become fatigued. So we are asking more muscle activity where muscles are not able to do the same activity with the available amount of oxygen. So by using anaerobic methods, the activity is carried off, and the byproduct is lactic acid. So lactic acid is built in the muscle. When we do the DTR or when we do any procedure, this lactic acid can come out of the muscles, right? And it takes a certain amount of time for the body to get accustomed to this. And initially, the pain may increase as well. In some cases, roughly around 30% of the cases, pain increases for 2 to 3 days. And from third day onwards, it starts going down. So what I do is that during first 2-3 days, if the pain is unbearable, then or if the patient is not comfortable, we can try combining it with muscle relaxants. There are also other serological tests that we do, of course, that vitamin D, D3, B12, ESR, uric acid, IgE, all these things have to be taken into consideration. And most of us, at least here in India, we have vitamin D and B12 deficiency. So even those factors have to be taken care, because a joint will not adapt if it doesn't have enough D3, or the muscles and nerves will not function well if they don't have adequate B12. So it's really a more comprehensive approach. And at times, my patients may say, doctor, oh my God, how many investigations do we have to do? But in a gray area for medical science, such as TMJ, we may have to invest a lot of resources in investigation and treat precisely, so that we don't do trial and error. We analyze thoroughly and treat very precisely. So I think, yes, we do pharmacological management of TMJ patients as well, especially chronic pain cases. We use medications as well. Medication, trigger point injections, very rare cases, Botox. Yes, but we do.
One more question, Doc. I just wondering whether you have seen any pain associated with the COVID-19 directly or indirectly, facial pain in your clinic. I'm just wondering, Doc. I never seen the publication or theory, but if you have any experience with that.
Yeah, unfortunately, the post-COVID patients do experience facial pain, headaches, and I'll tell you why. That is my philosophy, and we're trying to get some more data on this. However, in COVID, what patients are experiencing is the reduction in the weight. They're losing weight, right? The weight that they lose is essentially muscle weight. They lose muscle weight. So there is overall muscle wastage that is happening, and there is loss of muscle strength. And what your physiologic tolerance is all about is about muscle strength. So if your muscle strength is going down, your physiologic tolerance is going down, so you will feel that the symptoms are more post-COVID. There's weakness, there's more headache, there's so many things. So that is what is, I think, happening. And a lot of patients are complaining post-COVID that we have more facial pain than earlier after COVID. So I think that's the reason. But we'll know more in times to come.
Okay, thank you, Dr. Kunte. Maybe from Dr. Ernie, any question, Doc?
I have a lot of questions, but I think I will directly ask Dr. Kunte about that. Thank you, Dr. Fadil.
Thank you, Dr. Ernie. Yeah, Dr. Kunte, we have 168 participants in this webinar now, and from the various background, there is orthodontist, prosthodontist, from oral surgery, and I think there are so many questions that we can ask to you, because TMG is not the one part to the one specialist, but we can do the multidisciplinary approach to do the TMD treatment, I think.
It's a Pandora's box.
Yeah.
It's a Pandora's box.
Yes. Maybe all of the participants have you question. You can unmute your audio and directly ask your question to the Dr. Kunte, or you can activate your raise hand feature in the Zoom. Any question? Maybe from me, Dr. Kunte, the last from me. You write the one of contraindication in DTR is when the patient have this displacement without reduction. Maybe you can give us some explanation about it.
Okay.
Thank you.
So when we are creating new occlusion using DTR, what essentially we are doing is we are balancing the forces on the occlusion, right? We are making sure that there is even and uniform muscle activity, and muscles are relaxed in their excursion and they are active in the clench, right? Now, when we clench, bite hard, there is direct loading of the TMJ, all right? Now, this load is absorbed essentially by the disc, all right? So if the disc is not on top of the condyle, it is totally slipped, all right? It's totally slipped. And it is stuck in one place. It's not even going back. So disc has two poles. One is lateral, one is medial. So even if one pole of the disc is on top, then also we can do the DTR, because the disc, even one pole, let us say medial pole is on top of the condyle, but the lateral pole is slipped like this, fine. That medial pole will absorb that impact and it will cause stability in the craniofacial region. But if the entire disc is slipped, then what will happen is we may actually pinch the retrodiscal tissue every time we clench, that can cause more pain, swelling inside TMJ and hemarthrosis. So in that case, it would be difficult because, just a simple example, if your shoulder is dislocated, you will not be able to lift weight with that arm, right? So same way, if the disc is totally dislocated, it is very difficult to stabilize that patient in the long term. So it's better to get the disc back as much as possible with reversible means, and then do DTR or neuromuscular or orthodontics, or it opens up a lot of possibilities.
Okay, thank you very much, Dr. Kunte. It's very logic and simple explanation, because in DTR, I think in your presentation is very many movement in the protocol. I think movement of TMG. So maybe DDR is one of the contraindication. Okay, thank you very much for answer the question. Maybe before we close the session one, maybe any comment or testimony from our Dean, Dr. Muhammad Ruslin, MKes PhD SPBM Konsultan, kepada for Dr. Ruslin. The time is yours, Doc.
Thank you very much, Dr. Fadil. It's really great lecture from Dr. Farun Kunte, and on behalf of Faculty of Dentistry, we would like to great appreciate for you, and we would like to give you a certificate for your lecture. Is really excellent and very deep, and I hope this topic can be open our atmosphere to treat the problem about TMD. And again, thank you very much for your time and for your sharing knowledge and experience, Dr. Farud Kunte. And we hope we can do next session and next event with not in virtual, but in on live in our faculty, on our university. Again, thank you very much, and see you next time in our activity with Faculty of Dentistry, also together joint collaboration with Faculty of Dental Medicine, University of Airlangga, Surabaya. Again, thank you very much.
Thank you. Thank you so much.
Thank you very much, Dr. Ruslin. For Dr. Kunte, once again, thank you very much for your presentation. Such a great time to have you in this webinar. And I hope we would have another time to discuss about especially in TMG and TMG imaging, I think, because like I said before, understanding of TMG imaging is very complex. Okay,
Indeed.
thank you very much. And the certificate for Dr. Kunte, I will invite again our MC, Dr. Denis Setiawati, to conduct it. Dr. Dini, the time is yours.
Okay, thank you, Dr. Fadil, and also thank you, Dr. Kunte, for your fruitful and insightful presentation. Now, before we start the second lecture today, I would like to kindly invite the Dean of Faculty of Dentistry, Hasanuddin University, Makassar, Dr. Gigi Muhammad Ruslin, MKes PhD, SCBM Consultant, to virtually give a certificate of appreciation for Dr. Kunte's willingness to be one of our speakers in today's symposium and share his knowledge and experience with us about biometrics in temporomandibular disorders and disclosion time reduction. Dr. Ruslin, could you please?
Thank you very much, Dr. Dini. And again, thank you very much for Dr. Farun Kunte. And Harabi, this is your certificate. Again, thank you very much. This is your certificate.
Thank you so much.
And have time to give a lecture to our colleagues in Indonesia. Thank you very much.
Thank you.
Pleasure would be mine. Thank you.
Yeah.
Thank you, Dr. Ruslin, and also Dr. Kunte. Well, now we'll start the second session of our today's symposium lecture with Dr. Pianka Shaka Falkar, BDS, MDS, MSc, about CBCT application in dentistry. I will hand over again to Dr. Gigi Fadil to lead the session. I leave it to you, Dr. Fadil.
Thank you very much, Dr. Dini. And now we would move to the second presentation that will be delivered by Dr. Priyanka Sakafalgar. Let me read her CV before she presents her presentation. Our second presenter is Dr. Priyanka Umesh Sakafalkar, BDS, DDS, MSc. And now she is doctoral student in Alderhi Children's Healthcare Hospital, Department of Radiology in University of Liverpool. And for academic profile, she graduated from Maharashtra University of Health Science for dentistry and her specialization in oral medicine and radiology. After that, she continued her education in University College London in field of study advanced biomedical imaging. There are so many research publications that she conducted, and the latest is functional MRI, a promising modality for chronic orofacial pain in 2017, assessment and comparison of the capsular width of temporomandibular joint on ultrasonography and magnetic resonance imaging in 2016. Hello, Dr. Priyanka Sakafalkar. Maybe you have to unmute your... Dr. Sakafalkar, you still unmute? Okay. Okay.
Thank you very
Sorry. How do you do, Dr. Sakafalkar?
Yeah, I'm fine. Thank you. How are you?
Are you in London right now?
Yeah, I'm in Liverpool.
Okay,
Liverpool,
so I
I'm
have to say good
Liverpool.
morning, yeah?
Yeah, it's very morning here.
Okay. Yes, before you presenting your presentation, maybe I want to ask some question. I see in your curriculum vitae, you have many research use of various of imaging modality from CBCT, ultrasonography, and MRI. Maybe you can give us explanation about it, how you use all of the modality and how you enjoy without your job in dentomaxillofacial radiology.
Okay, so speaking about my research on ultrasonography and MRI, firstly, it was very wonderful lecture by Dr. Varun. I learned a lot of things today about TMJ. And that was my first research during my post-graduation in India. And when we are talking about TMJ, the MRI is the gold standard, we all know. But when we are speaking about countries like India, and perhaps, I don't know, probably Indonesia as well, the patients do not have the capacity to pay for MRI. And then MRI's availability, it has many disadvantages when we are talking about scanning with MRI. And every patient cannot afford. So we were trying to see that if we could have some preliminary advanced imaging modality like ultrasound, by which we can do preliminary imaging and find out if patient needs MRI, or if we can come to some conclusion. That was the main aim of the project. And we did find, it was a very small research group, and we did find that the ultrasound was effective and it was helpful with the preliminary studies. And more research is needed. So if we could, that was the first aim. But then after, I was always fascinated by advanced imaging and different imaging modalities. So after my post-graduation in oral medicine and radiology, I worked at Conebeam CT Center as a consultant in Pune, India for a year. Then again, the passion for research, I moved to UK. And I did my advanced biomedical imaging. And there my research was, I moved to brain imaging from there. And my research was a functional MRI for brain imaging. And we tried to develop the another technique to measure blood oxygenation. That was the aim. And now at Aldehay Hospital, I'm working on the technique to understand the post-radiotherapy changes with, again, MR imaging. And we are using, the technique which I'm using is radiomics, which is, again, the very advanced imaging by which we could, the problem with the patients with, pediatric patients with brain tumors is that they have a lot of side effects after the therapy. So aim of our my present research right now is that if we could reduce their discomfort and if we could predict if these patients are going to have these lifelong side effects, we might be able to make their life little easier, because having a brain tumor in a child is very heartbreaking, to be honest. So it's just a small effort if we could help these patients and their families with the research. So that is my research right now. I'm not working with dentistry at the moment or CBCT, but I'm working with imaging and MRI and other advanced things.
It's awesome, Dr. Sakafalkar, because I think you are expert in all of the imaging modalities.
I'm humbled with that. I think there is so much to learn from.
Yes, because in Indonesia, we might use the CBCT as the advanced modalities in field of dentomaxillofacial radiology. So your presentation today is very related with us.
Okay. So are you using CBCTs regularly? Do you have CBCT in your institute?
Yes, we use CBCT regularly.
Okay, that's great.
Yes, because so many referee from the other specialty to us.
Yes.
So we use CBCT more.
Okay.
Than the other great modalities.
Okay. It's a very basic lecture. I'm targeting mainly general dentists to like what is CBCT and how does it work. It's not very advanced, but if you want some more about specifically imaging and TMJ with other modalities, we can talk some other time.
Okay, in this session, Dr. Sakafalkar will deliver a presentation entitled CBCT Application in Dentistry. And for all audience, you can write down your question and your name in the chat box during this presentation, and I will read your question in Q&A session. Well, Dr. Sakafalkar, you will have approximately 30 until 40 minutes for presenting your presentation, and 10 or 15 minutes after that would be the Q&A session for your session. Ladies and gentlemen, please welcome Dr. Priyanka Sakafalkar. Dr. Sakafalkar, the time is yours.
Okay, thank you. I will share my screen. Okay. So good afternoon, Namaste and Assalamu alaikum, Indonesia. And it is very nice to be here again. We have met before and I'm very glad to join again. And this time I will be speaking about my specialty and subject. Before it was a different topic. It was on mindfulness, but I'm very glad to be here again. Now, being a radiologist has always made me curious about shadows. And when I saw this beautiful shadow of Lord Ganesha on the wall, I imagined one beautiful statue of the Ganesha giving rise to this shadow. However, on looking at, going into details, what I realized to my surprise that though there was a shadow, there was not a real statue, but something appearing like that one. So this gentleman has made something that resembles the statue made up of stationery. And so shadows can be deceptive. And now when we are coming about speaking about the 2G imaging, similarly, when we are talking about it, I would say radiology and 2D imaging is more of a shadowology, because the shadows we see can be deceptive, just like the previous example. In addition to that, if there are two structures close to each other, like in this image, if you see this one and this one, they will produce the same image. Because, for example, if this is a nerve and this is a tooth, we do not know what is the exact position with the 2D imaging. It can be all this, whether the tooth is positioned here, it is positioned here, it is positioned here, or even in the other way, if this has been on this side and this has been with this side, if this is the source of X-ray and this is our film, it all will produce the same image. Again, another disadvantage of 2D imaging, they are superimposition, distortion, magnifications, foreshortening, etc. So we do see that 2D imaging or the conventional X-rays are insufficient when we are talking about imaging and when we are trying to treat our patients in a good way. So with this background, I would like to start my lecture today as the CBCT applications in dentistry. And actually, they have already done my introduction. I'm presently doing my doctoral studies at University of Liverpool and Alderhay Hospital in UK. And I was also a consultant dentomaxillofacial radiologist, where I was working with CBCT at Pune, India. Okay, so it will be very general lecture for the dentist, and we will be speaking about limitations of 2D, which we have already talked about. And what is CBCT? How does it work? Its application in different areas of dentistry, its strengths, limitations, and we will come to conclusion. Meanwhile, I will also share some of my very interesting cases when I was working as a consultant. And I think most of you are already aware of CBCT because it is not that new now. So what is, starting with the very basics, what is cone beam computed tomography? So cone beam it's the cone shape, and the computed tomography, the definition of it is the method of producing three-dimensional image of an internal body structure by computerized combination of two-dimensional cross-sectional X-ray images. And cone beam technology uses a divergent pyramidal or cone-shaped X-ray beam. Since this beam is cone-shaped, it is called as cone beam. And computed tomography is the normal CT, where we try to reconstruct the 3D image from the 2D images, multiple 2D images or 2D slices. Origin, initially, CBCT was built for angiography in 1982. And it is also used for radiation therapy, dental planning, and other ENT applications. And CBCT it has been existed for a very long time, but only over the past 2 decades, I would say, clinical system, both inexpensive and small enough. Because of a lot of technological advances that happened in the recent duration, we could take this imaging modality into dentistry and to use it for our benefit. Now, how does it work? Firstly, there is a source, X-ray source. This is the patient, and this is the receptor. Whenever X-ray source produces X-ray images, it hits this, it irradiates the patient structure, and image is produced on the receptor. This image is later sent to the computer for the 3D reconstruction. So basically, it's the 2D image that is produced. And first, imaging is accomplished by rotating a gantry. So this is the X-ray machine for this example. CBCT machine, I would say. And this is the source of X-ray, which is cone shape. This is the patient, and this is the receptor. So by using the gantry to which X-ray source and detector are fixed, a divergent pyramidal or a cone-shaped source of ionizing radiation is directed to the middle area of interest into the area of X-ray detector on the opposite side. Now, the X-ray source and the detector rotate around the rotated fulcrum fixed within the center of region of interest. During the rotation, they may be from 150 to more than 600 sequential planar projection images of the field of view are acquired in a complete or sometimes partial arc. And these projections are made from multiple angles to capture the entire volume of the region of interest, and then the internal structure of the object can be reconstructed from the multiple projections of the object. Now, because the cone beam irradiates a large area instead of thin slice, we do not need to rotate many times. We just rotate once, and we get all the information necessary to reconstruct the area under examination. So this is the comparison with conventional CT, which is the fan-shaped beam. So basically, CT is the CT. In cone beam CT, they are using cone-shaped beam, while in conventional CT, they use fan-shaped beam. And the image construction in this in cone beam CT, it is more of a volumetric, but in fan beam, the image is captured slice by slice. So we can see the slices in the conventional CT. Okay, so how are they different? When these machines were introduced, their main advantage was the lower dosage of radiation in comparison to medical CTs. Now, this may not be exact true with the advances in CT as well. But to go to the basics, the fan beam CT is the more apt for the medical use than the dental use, while CBCT is more apt because it produces low dose, low cost, and less space. CT might be more accurate, we can say that, because we can even measure the volume or the Hounsfield's unit. We cannot do that with CT, but with advances in softwares and different technology, and even the different specially designed dental softwares can help us to use CBCT with precise measurements in all dimensions. Now, these are different cone beam CT machines. They are in the practice now. Here, the scan can be taken from the sitting or the standing position. Here, the source of X-ray, and this is the receptor, and this rotates around the patients when image is captured. Again, this is another machine where this is patient sitting, a source of X-ray, and receptor. Now, then we are talking about display modes of CBCT. Now, after taking this image, how does it look? So on the CBCT scan, we got these 4 images, and starting with this is the 3D image where there is actual reconstruction of the bone and everything. This is the axial image. Axial image is the one which is parallel to the floor. The sagittal image is one which is passing through the sagittal suture, separating right from the left in the coronal plane. This one, the passing through the coronal suture, separating from the front from the back. Now, basically, we can see this big panoramic view, and then we can select each region or each tooth, and we can see it from different sides as if we are slicing, and we can see it from each aspect on each side. Now, when we are comparing the radiation exposure with the CT, it is far less than medical CT, and scan time is also less, which is exposure time is just 2 to 5 seconds, and the scan time is less than CT, and exposure time is still lesser. In CT, patient is continuously exposed to radiation throughout the total scan time. However, in CBCT, X-ray beam can be pulsed, so that actual exposure time is just a fraction of total scan time. This leads to drastic reduction in the radiation doses of CBCT as compared to its medical counterpart, that is CT. Now, comparing with the dental imaging, the effective dosage of large FOV. So field of view are different areas that are covered in the CBCT. So if we are covering large FOV, that is 6 to 12 inch diameter, the CBCT scan is 2.7 to 25 times that of panoramic radiograph. However, if we select the only region, so this is the large FOV, maybe covering both the arches. If we select the very small FOV, for example, if we just want to see the canine or if we want to see the third molar, the CBCT scan is equivalent to the panoramic radiograph or maybe a set of bite wing radiographs. Coming to the resolution of large FOV CBCT scan is equivalent to that of panoramic radiograph, and image resolution, if it is the very small FOV, the CBCT scan is equivalent to that of IOPA. But I'm afraid if it is very large FOV, we do not get as good resolution as IOPA, because then again, there are a lot of factors when image is reconstructed with CBCT. Coming to the patient selection criteria. First, it is very important that we practice safe dentistry, and we are very responsible. We are working with the radiation. It is important to remember that the CBCT provides radiation dose that is higher than other radiographic procedure. So principle of ALARA, that is as low as reasonably practiced, must be applied. and the potential diagnostic benefits are greater than the detriments by treatment. Again, whenever we need to analyze the benefit to risk ratio. So we need to be very cautious with CBCT, using CBCT, whether patient really needs it. And indication for CBCT examination should be documented in patient chart or request or prescription. Now, CBCT has several applications in different parts of dentistry, and I'm sure many of you have used CBCT now. It has applications in endodontics, periodontics, oral surgery, implant planning, TMJ, ENT, and other applications that we previously spoke. Starting with the endodontics, which is, there are 5 specific imaging tasks in endodontics where the CBCT has distinct edge over conventional 2D radiography. Post detection of periapical pathology. We can see this pathology from all the aspects. For most of the cases, IOP is enough, but if the patient, there is a recurrent case of pain, or the patient is not, periapical pathology is not getting healed, it is good to think of a CBCT scan. Then when there are doubts with the assessment of root canal anatomy, if we need to do the pre-surgical assessment, the positioning of the root, association with the nerve structure nearby, then assessment of dental trauma, or even the treatment outcome, CBCT can be helpful. Now, this is the case with the persistent pain after the therapy. And here we can see, this is the conventional X-ray, where we can see the radiograph, the periapical lesion. But with the CBCT from different plane, we can see there was a horizontal fracture. It is very difficult to appreciate it with just one slide, but if we see the sequential slide and if we see the reasons, we can see that there was a horizontal fracture with this patient. So that was the reason of persistent pain even after the treatment of the patient. Now, root canal anatomy. Now, this patient was referred for failed RCT, and with CBCT, we tried to see it with the CBCT, that what was the cause for the recurrent pain of this patient, and RCT was not being able to done properly. So when we saw this, so this is 2-1, this is 2-1, and we see it in the imaging in the 3D view. This is axial. We can see this is the morphology. It's slightly different from this. And even in the coronal, we cannot see the root canal properly. But when we are looking at from the sagittal plane, which is not possible with IOPA, we could see that the root canal morphology, the anatomy of the canal is completely different in this 2-1. Instead of this straight, if we see that this is completely curved. I don't know if this could be because of the trauma patient might have underwent during development, or what was the reason, I don't know. But that was the reason that proper RCT could not be done in this patient. If you see this, the canal anatomy is completely distorted in this 2-1, in this particular patient. Now, unfilled canals. Unfilled canals can be seen on IOPA, but not always. If there is superimposition with the other roots, we do try, definitely, we always do try the taking another X-ray from different angulation to see use the slog rule or take 90 degree for the exact localization. But it is not always accurate or sufficient to do that. And when we are talking about CBCT gives us a complete picture. Now, for example, in this patient, this is the sagittal view, okay? Sagittal is the right-left. We can see that the root canal, this canal is not completely filled. We can see that in the lower third, this was not, it is not reaching the periapical region. And that's why patient had the pain even after RCT. And if we see it from the axial plane, we can see that the distal 2 canals in the distal root, there are 2 canals which are incompletely filled, they are not filled. And in the apical third, all the canals, like all the canals from the mesial and distal root, they were empty. They were not showing this material, periapical, maybe GP or any other feeling. which should have been here. So if we can appreciate, if we cannot see the canal, if we cannot locate the canal, or if there is persistent pain even after the root canal therapy, it is a good idea to go for a scan. Now, vertical root fracture and perforation. So it is always difficult to determine vertical root fracture. Of course, we have a test where we ask patient to do a bite and then try it. But with CBCT, we can clearly see the vertical root fracture if it is there. Now, for example, in this patient of 2-6, this is the axial plane, and this is, we can see this slight black line showing that, showing the fracture, and we can see it in the other planes as well. This is the coronal plane, and even in sagittal plane, we can see this is completely cracked tooth due to trauma. And even we can appreciate that the 2 canals were not properly filled in this patient. And not just this, this has caused the periapical lesion, but not just periapical. This is the maxillary sinus. And this is all this infection has caused the opacity in this maxillary sinus. So we can appreciate not only the tooth, but associated anatomical regions as well. Now, there is an interesting case. She was a patient with the history of, she was a doctor herself, ENT surgeon with a history of persistent pain after RCT. And we tried to evaluate her on the CBCT scan. And when we took the CBCT scan, because she was complaining of persistent pain and RCT has not helped her, we could see that a broken instrument in this patient. And it was very interesting to see that this is the broken instrument. It is axial scan at a very lower lane. This is the very lower level. And if we can appreciate it in the coronal plane, that this is the tooth root and it has completely gone down. This is the inferior alveolar nerve canal. And this is the file. I don't know what instrument it is. And I'm really curious how come it went this deep. But it was very deep. And this is very close to the alveolar nerve. And it is very unlikely that we take a radiograph this deep to find out that instrument breakage has happened and it has gone this deep. And sadly, this patient had to go for the very bigger surgery under a GA to get this instrument removed, which was detected with the CBCT. But patient was happy later. Now, periodontics. With periodontics, we can see the tooth from each aspect. Here we can see the interradicular bone loss in this patient, or even the presence or absence of buccal or lingual plate. And this is again this interradicular bone loss, the furcation involvement from the lower plane, or the different angle, that's the axial plane. Now, coming to oral surgery is the most common. Obviously, after implants, I would say oral surgery is a very common area where CBCT is useful. And so this is the patient with the cystic lesion in the 4-8 region. And we can, with CBCT, so this is the normal panoramic view. But if we see that this is the 3D view, this is axial view, we can appreciate and measure the complete length of the cystic lesion. And we can also understand the association or the relation of this lesion with the corresponding nerves. We can see here the inferior alveolar nerve. We can see that missing the buccal plate in the 4-8 region. There is no bone structure here. And we can actually measure the cyst from all the sides. So maybe anterior-posterior or the superior-inferior, whatever is the dimension of the cystic lesion, we can appreciate. We can also appreciate, so this is the nerve, which was very close to this 4-8. So when we have this clear picture, the surgeon can plan surgery very well. We can inform patient that there are chances of damage to the 4-8. And I think with better picture, and now we have got 3D printing as well. So if they have better picture, we can prepare patient, or we can be prepared for the complication that might arise in this patient, because we know exactly what it is and where it is. Now this is another interesting impacted tooth, which is this is the 3D image where we can clearly see it is the horizontally positioned tooth, and this is the lesion which has caused the bone loss or the cavity in this anterior region. Now impacted molars. It is very common for impacted molars to be close to the inferior nerve canal. But in this particular patient, if we see, this is the panoramic image, and we can see that this is just closer, but we don't know whether it is, where it is this nerve exactly, whether it is on the buccal side, whether it is on the lingual side from this panoramic. But when we are taking the CBCT scan, it was very interesting to see that this is the distal root and this is the 3/8. But when we are seeing it was this nerve canal is passing between the two roots. So it was having a very strategic location, and it needs extra care by extracting, because it is not just close to the tooth root, but passing between the two roots.
Sorry, Dr. Sarkavalkar, you have 15 minutes left.
Okay, thank you.
Thank you very
for
much.
letting me know.
Yes.
Okay, now speaking about the complicated position. Now this is the 1/8, which was horizontally, we can see this was horizontally positioned. But what was most interesting about this patient is that its roots were interspersed between the 1/7 roots. So if we see from this aspect, which is very clear, if this is the coronal scan, that is from anterior and front, we can see that this is 1/7. This is the palatal root, this is the buccal root of 1/7. And we can see 1/8 having one of its root between the buccal and palatal root of 1/7. And that was one finding. Another finding was it was very close to the floor of the maxillary sinus. So if we see, this is the floor of the sinus and this is the 1/8. It was a very thin line. So there are great chances of damage to the maxillary sinus while extraction of this tooth. And of course, it will need extraction of, or perhaps it might, of course, it's the oral surgeon's call, but perhaps it is very likely to take the extraction of 1/7 as well while extracting this tooth. Now, these are additional things which we might find, especially in the oral medicine clinic, if we are looking for the salivary duct calcification. Now, in this patient, we can clearly see this, the salivary gland calcification. And we can appreciate it in all the scans, this calculus, from the coronal, sagittal, and axial plane. And in 3D also, we can clearly appreciate the scan. Of course, we can see even the styloid processes in some of the patients. If there are calcified process or the ligaments, we can see them as well. Now, maxillary sinus, we obviously previously have seen some of the complications that are seen in maxillary sinus. But in this patient, we could see the foreign object. It could be the dislodged root piece or some other, we don't know. This is seen in the 3D image. And this is called cause the opacity in the maxillary sinus. This is the root of 2/7. And from another angle, we can clearly see this is the foreign object that is there in the maxillary sinus, which needs some investigations. Now, speaking about orthodontics, orthodontics is also very common. And if we see supernumerary teeth, patients with supernumerary teeth, they can have some complex alignment at times. Now, in this patient, this is the maxillary arch. We can see that this is the 6/3/2/2. It's a very complicated picture, 1/1. And there are two supernumerary teeth. Okay, and this is the 3D scan. I'm sorry, it's other way around, but Even though that is the advantage of CBCT, we can rotate it in any way we want. So this was the best view I could see. And so these are the different teeth, and these are supernumerary teeth. With the coronal scan, we can get a very clear picture of this. So this is the 1-1, this is 2-1, 2-2, and this was the supernumerary teeth. So patient had 2 supernumerary teeth which had complicated arrangement. One was horizontal, and then 2-1 was completely impacted and positioned very superiorly as compared to supernumerary teeth and 2-2. So this is the conventional panoramic view of this patient. Now, implant site assessment. It is the greatest impact of CBCT is on the planning of dental implant. And I think 90% of the scans are advised for the implant site assessment, because it provides the cross-sectional imaging, provides association of vital structures, let it be inferior alveolar nerve canal or the sinus, all other important anatomical structure we need to consider while implant placement. The advantages of CBCT, as we have already discussed several times, they are about axial, cross-sectional, and reconstructed panoramic. We can see from all the angles. Now, if we see in this image, this is the 3D image. We can see the alveolar bone, and we can meter it. So now, for example, if we see this is the axial plane of the mandibular arch, this is the panoramic. And if I have selected this region, CBCT, and in this particular region, I can actually do the measurements of the bone height and the bone width of specifically of this region, so that implant can be placed at the ideal location. And also we can also decide the angulation, because we can see this is how it is positioned. And useful series of images, all different angulation, gives us a better picture and provides precise reference for the location of the proposed implant site or the proposed teeth. Now, with the advanced software, we can actually even simulate the implant placement. We have advanced softwares where we can exactly select the type of implant that we are planning, the dentist is planning to do it. And at the CBCT center, we can position it and we can simulate it. Now, not just implant placement, but with the post-implant assessment, whenever there are some complications now in this patient, if we see that this implant has completely broken the floor of maxillary sinus, we can see opacity of the sinus. And from another view, again, this was the floor of the sinus, and it was not giving complete picture. It doesn't have the proper bone support that it is needed. Again, this is into the sinus and associated opacity of the sinus in 1-4 region. Coming to the TMG assessment, of course, Varun gave a wonderful lecture this morning. Now, it provides a multiplanar and potentially 3D images of condyle and surrounding structure, facilitates analysis and diagnosis, and it is very critical to providing appropriate treatment outcomes. And it can depict the features of degenerative joint disease, developmental anomalies, ankylosis, and rheumatoid arthritis disease. Now, this is the image, a panoramic image, and we can see this is the right side of the condyle and left side of condyle. And we can see that left is the normal, but right, we can see the pathology in this patient. Now, a rare incidental finding, when I was scanning a patient with TMJ pain at the CBCT center, we could see that so this is the 3D view, head of the condyle, and this is the glenoid fossa. We can see in this patient, when the sections were taken, we can see this multipolar small cyst within the articular eminence. This is the rare finding. But this might be the cause of pathology, this may not be, we don't know, but we could see this multiple cyst in the articular eminence region in this patient. Now it has ENT applications like the sinus troubles, we can see this opacity. Airway assessment, it can be used for airway assessment. with mouth breathing and other nasal morphology. There are advanced softwares available to do that now, but we need a large field of view for airway assessment. Now, coming to the strength, first size and the cost. It is size and it can be fitted into the dental clinic. The machine does not require a very large space. We can get high-speed scanning, good resolution, low patient radiation dose as compared to CBCT. And we have interactive analysis and advanced softwares to use in CBCT. Limitations, the cost, it is slightly expensive than the conventional 2D imaging. Availability, now it is becoming more and more available. So it may not be a big issue right now, which it was previously. And it has radiation dose higher than panoramic 2D. And there can be metal artifacts or other scanner limitations with CBCT, but this is beyond the scope of our lecture today. Now, coming to the clinical value proposition, we need to make a good balance between desired diagnostic information, risks and cost, time, efficiency, and whether it will benefit patients or not. So in conclusion, CBCT provides the anatomical data that can generate a collaborative treatment plan and achieve optimal outcomes for all the aspects of dentistry. And it's a comprehensive diagnostic modality encompassing all the branches of dentistry. So next time, if you are in doubt with the underlying anatomy or diagnosis and IOPA, a panoramic is unhelpful. Remember to go for CBCT imaging instead of imagining. Thank you very much. If you would like to get in touch with me, you can get in touch through email. I'm there on Twitter and LinkedIn as well. Thank you.
Thank you very much for your amazing presentation, Dr. Sagafalkar. Very interesting, I think, because you give us the overview of CBCT use in dentistry in common case and all of the various specialties. Thank you very much. Okay, we move to the Q&A session, and we have 2 questions in here. I try to share screen from PowerPoint. The first question from Dr. Ernie Marlina. She asks you, from your experience, how small the salivary gland calcification that can be detected using CBCT? Okay, for Dr. Sagafalkar, can you answer it?
Yes, thank you, Dr. Ernie, for the very practical question. But it actually depends upon the calcification, amount of calcification of that patch, and also the resolution of the CBCT that we have. It will also depend upon whether patient has other metallic restorations or the orthodontic appliances, because it reduces the quality of CBCT image that we receive. But I think even as less as 0.3 or 0.5 mm, we can detect it, but we'll have to be very careful and we need to exactly know what it is. It will depend upon the calcification, but yes, we can detect it. Maybe 0.3 or 0.5, I think we can detect it.
Okay, any response, Dr. Ernie, about?
I will try to observe how small we will, because I never have any experience with CBCT for calcification in salivary gland. But thank you for the overview.
Thank you very much, Dr. Ernie. Yeah, interesting that Dr. Sagafalkar write in the conclusion slide, CBCT imaging instead imagining, because I think we are not like Oracle. Yes, we have to evaluate in the CBCT imaging that can get volumetric reconstruction of the object. So I think for the future, I think CBCT is a must. Maybe like that, Dr. Sagafalkar. Any idea?
Yeah, it is very important. And when we have this, if we have this facility, why not to use it? Because we are just making a dentistry safer for our patients with the better prognosis. If we could see it exactly what it is, if we could see where the nerve canal is, or if we could see where the floor of maxillary sinus is, we are less likely to make a mistake and practice a safer dentistry. As a responsible dentist, I would say, if we have facility, we should always go for it.
Okay, thank you. The second question from Dr. Arizal. He is a student of orthodontic specialist program in Hasanuddin University, Makassar, Indonesia. He asks about what the meaning of complex alignment and how CBCT can evaluate it. Maybe related with his field in orthodontic. So he asks you about what the meaning of complex alignment and how the CBCT can evaluate it.
Okay,
Please,
so
Dr. Sakafalkar.
Thank you for asking this question, Dr. Rizal. Complex alignment means whenever, like the photos or the case that I presented, in this patient, there was not single supernumerary tooth, there were multiple supernumerary teeth. And they were not just in between. So if we are speaking about mesio-10s, they are normally positioned in between two centrals and it is easy to extract. You don't have to worry about that. But in this particular patient, these two supernumerary teeth, they had completely displaced to 2-1 to the superior position. And they had a complex root positioning between the 2-1, 2-2 and these two supernumerary teeth. So having this picture would help, not just help oral surgeon to extract, but this will also help for the orthodontist to plan the realignment properly. I hope that answers your question.
Thank you,
And
Doctor.
this is not just about the anterior or supernumerary. Yeah. It can be about impacted canine. It can be about any other extra tooth the patient might have. Patient might have supernumerary or any other complex root arrangement, which you cannot determine with 2D OPG or the lateral cephal, which is normally done in the orthodontic practice. In fact, there are more advanced softwares as well, especially for the orthodontics, where we can actually simulate the orthodontic treatment that can be done, or what will be the final appearance of the patient after we put the inputs and after our therapy. Thank you. I hope that.
Okay, thank you very much, Dr. Sakafalkar. So I think in orthodontic purposes, we have to combine with the other imaging modalities, right?
Yes.
Yes, thank you. Then the next question from Dr. Aga Satria. He is a dentomaxillofacial radiologist too in Indonesia. Hello, Dr. Aga. Still speaking of previous topic, which is TMD and TMG, he asked how accurate CBCT in diagnosing any TMD, because what can we see through CBCT in TMG? So we can easily diagnose it as a TMD or like this displacement. Is there any specific signs or any particular guidelines for the normal measurement of condylar space width in glenoid fossa, and how accurate is it to predict the TMD? I think he asked about how CBCT can predict the TMD accurately in some cases. Thank you, Dr. Aga. Dr. Sakafalkar, yes.
Sorry. Okay, so it's a very good question, and it's a very complex question. I don't know if it is.
You get it. You get it. You get it, Doc. You get it. The point.
Sorry, just to give the guideline or hint to the general dentist who might be practicing and seeing this video today, is if you are suspecting a bony pathology, so whether there is any problem with the condyle or the articular eminence or any arthritis, if you are seeing that symptoms of these symptoms, it is good to go for the CBCT. But if you are trying to see any soft tissue pathology, so maybe disc or other ligament, it is MRI is the better imaging modality for that, because you will not be able to see the capsule with TMD. There are certain measurements and research, but that is insufficient to go with the CBCT for the soft tissues at this point. I hope that helps.
Okay, thank you, doctor. So in TMD, like Dr. Kunte before said that it have to multidisciplinary approach, and I think multi imaging, so multimodalities. I mean, yes. Move to the next question from our lecturer in Hasanuddin University from Conservative Dentistry, Dr. Maria Tanumi Harja. Hello, Doc. She asked you, how do we decide to process the CBCT from IOPA? Thank you.
Okay, so it's a clinical judgment, but if we cannot get the sufficient information from IOPA, for example, if you have treated with root canal and patient is not getting a relief, you would like to see it again, that if there is anything unfilled canal or any other complications in the periapical region, that would be the indication. Or even in cases of third molar extractions, if with the IOPA, if you cannot, even with the panoramic, at times it is very difficult to understand the position of the root of the third molar with the inferior alveolar nerve. In that case, it is always safer to go for the CBCT and know the exact position, because with CBCT we can almost measure the distance of the nerve from the position of the root, and if whether it is within the root. Whenever there is a doubt, and conventionally we use the slop technique, as you know, we take another radiograph from the different angulation, we move the tube and take IOPA from other angulation to see whenever we are having some impacted tooth or we want to determine the location. But CBCT is the more accurate way when you think that this is insufficient and you need more investigation. I hope that is helpful.
Thank you, Dr. Sakavalkar. Any response from Dr. Maria? Are you there, Doc? So maybe we have to consider the indication, yeah, Doc, because
yes.
Some case we have to more information. We need more information. So in some cases we have to refer to CBCT scan. Okay, there is a response from Dr. Maria. Thank you very much, Dr. Sakavalkar. Next, I try to share screen again. The next question.
Okay, so I can see a question from Dr. Sandy.
Dr. Sandy, okay. Yeah, he asked you about now we recognize the new concept of radiation protection, namely ALADA, as low as diagnostically acceptable. So what do you think about it? And should we choose CBCT as primary imaging for all cases, or should we just use CBCT only if conventional imaging can give us the information that we need? I think related with the question from Dr. Maria and what we discussed before.
Yes.
Please, Dr. Sakavalkar, you can explain more.
Yes, thank you. It's a very good question, and it's a very responsible question again. I don't know about each country has its own guidelines, and in UK we have IRR guidelines which are strictly followed whenever we take any radiation, we give any radiation dose to the patient for when we or do any scan. So in order to protect our patients from unnecessary radiation dose, it is always important to go for the conventional imaging. Unless it is necessary to go for the CBCT, I would not take CBCT as the replacement for the all primary imaging, because many times the IOPA is sufficient in most of the cases. When we can see everything from IOPA. If there is 1 or 2 and you need to do the root canal, I don't think you need CBCT for that. It's a single rooted tooth. So in that case, I would not expose the patient to unnecessary radiation with CBCT, which I can see through IOPA or the simple imaging, and it will protect the patient. And each country has, if you want to see the guidelines, there are IRR guidelines. I think they are available online. It is for UK. And there are many articles about the radiation protection and dose of CBCT. If you get in touch with me, I can send you those articles. Hope that's helpful. Thank you.
Thank you very much. Any response from Dr. Sandy? You can unmute your audio or raise hand if there is any response. How about the resolution, Doc, between the CBCT and IOPA? I think it related with when we need the CBCT or just IOPA, or is not related with it.
If you ask me, my personal choice would be IOPA, because IOPA has got very nice resolution. And CBCT, we do reconstruction, but then software has its own limitations, because CBCT is not seeing everything. It is reconstructing from several 2D images. And yes, there are better scanners. Software is getting better, but if you're talking about a very minute resolution, I would go for IOPA.
But in the right technique, I think the IOPA in right technique, because right technique can produce the right image, I think, Doc.
Yes.
Okay, thank you, Doc, for the explanation from Dr. Agasatria and Dr. Sandy. Any question from all of the participants? Okay, in the chat box, I see no question again. So maybe I ask the Dr. Sakafalkar to give us something like a closing statement from your presentation today.
The closing statement is again the same one. Instead of imagining, go for imaging. Whenever you are in doubt, let's practice the safer dentistry. Whenever in doubt, obviously considering the radiation dose.
Okay. Okay, thank you again, Dr. Sakafalkar, for answering the last question and for the great presentation. It was a pleasure to have you with us. And before you leave this session, I would like to say once again, thank you very much for all the presenters today for their informative and great presentation. Hopefully the presentation will be beneficial for us. And very well, ladies and gentlemen, thank you very much for your kind attention during this webinar. See you in the other virtual symposium. And before we leave it, I turn back to our Master of Ceremony, Dr. Denis Setiawati, to conduct the virtual speaker certificate from the Dean of Faculty of Dentistry of Hasanuddin University to Dr. Priyanka Sakafalkar. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Fadil, and also thank you, Dr. Shaka Falkar, for your very thoughtful and lucid presentation. Now, I would like to kindly invite the Dean of Faculty of Dentistry, Hasanuddin University, Makassar, Dr. Gigi Muhammad Ruslin, MKes PhD SPBM Consultant, to virtually give a certificate to Dr. Shaka Falkar to appreciate her willingness to share her knowledge and experience with us about CBCT application in dentistry.
Thank you very much, Dr. Dini. For Dr. Priyanka Sakafalkar, thank you very much for your time and also for your sharing your knowledge.
Thank
and
you.
here be your certificate. Again, thank you very much.
I would like to thank Dr. Ernie, Dr. Rahman. It's an absolute pleasure to be with you today and speak to you. I hope this was helpful to you. Thank you.
Thank you, Dr. Ruslin, and also Dr. Shaka Falkar. Okay, we are almost at the end of our symposium today. Before then, I would like to kindly re-invite the Dean of Faculty of Dentistry, Hasanuddin University, Makassar, Dr. Gigi Muhammad Ruslin, MKes PhD SPBM Consultant, to give closing speech. Dr. Ruslin?
Thank you very much, Dr. Dini. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon, everybody. Today, our activity already finished, and on behalf of Faculty of Dentistry, we would like to say for the Honorable Dr. Farun Karante and Dr. Priyanka Shahfalkar as our speakers today. And ladies and gentlemen, and all distinguished participants, Alhamdulillah, all praise and gratitude to Allah Subhanahu wa Ta'ala, so that we all have the time and opportunity to participate this event, Virtual International Symposium Series, with theme Advanced Imaging and Dentistry, that organized by Faculty of Dentistry, Hasanuddin University, in collaboration with Erlangga University. I am very happy and delightful with all participants of all fellows. And ladies and gentlemen, it's an honor for us to able to meet and have share knowledge in these occasions. As a clinician in pandemic situation, we need to be creative and, of course, constantly update our knowledge and be open-minded about TMG and disclosion, time reduction, and CBCT application into our preparation. Hug, gratitude, and respect to distinguished speakers, Dr. Firun Karunte, and also to Dr. Priyanka Shahfalkar for providing the opportunity for your shared valuable knowledge and experiences with us. We we could have you in a person in our city of Makassar, probably after pandemic over. To all participants, I hope you had an interesting, productive time and simulated discussion during this symposium, and apologize if there's inconvenience in this event. I really hope to see you again in our next international and national events. Once again, I thank all of you joining in this symposium and look forward to seeing you again. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Ruslin. Ladies and gentlemen, before we end our today's symposium, I would like to inform you about our next scientific meeting agenda or schedule. Please feel free to attend in our next schedule to enhance and refresh your knowledge about current topics in dentistry or dental science or technology. Please just spare your time to read our information in your screen. So we have a topic in our next virtual international symposium series. We have a topic about long-term management for potential malignant disease or OLP. So please feel free to register yourself in the link in your screen, or you can capture your screen to do registration later on. Don't forget in 19th of May. Please feel free to attend in that meeting or symposium. Okay, this is the end of the 8th Virtual International Symposium series today. It's very interesting to see many of you here and hope you can take benefits from the lectures in our today's symposium. Hope to see you again next time. Thank you for all the attendees. Stay safe, stay healthy, have a good weekend, and happy Ramadan Iftar time in the next few hours for all Muslim attendees. Thank you.
Thank you, Dr.
Thank you, Dr. Dini.
Thank you, Dr. Uslin,
Dr. Ruslin, Dr. Reni,
Dr. Ulil.
Sumbangan, and all of the participants. See you.
Selamat berbuka puasa, sehat selalu semua dok, Prof. Sehat selalu Dr. Dini. Terima
Sehat ya,
kasih.
Dr. ini masih terus terima kasih Dr. Fadil.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.